webinar. And Matt Goldenberg is going to be a co-host, but we had a little scheduling snafu, so he's going to be a few minutes late. So this is coming to you from the Center for Professional Recovery. It's the program that Matt and I work at. We do professional evaluations and treatment. And I just thought I'd go through a little disclaimer. So I'm the medical director. Matt, who again will join us shortly, is our lead addiction psychiatrist. And I'm also medical director of Professional Boundaries, Inc., which is the PBI education program. And I also do consulting for drug testing and professional impairment issues. And Matt is also in private practice of addiction psychiatry in Santa Monica. So we are there at that red dot, and that's Malibu, California. And as you see, those of you that don't know, it's like actually due west from downtown LA, surprisingly. This is a picture of the outside of our treatment program. We do group rooms and different living room areas. There's the kitchen and there's the backyard. You can see the ocean in the distance. It's a very nice facility. Okay, so let's get into the material that we wanted to discuss. So what is failing up? So I first heard this term when Matt used it. I guess Dr. Miato had used it with him. Anyway, it's the concept of treating an individual with a substance use disorder at a lower level and less expensive level of care, with the plan that if they fail, then and only then would they be moved to a higher level of care. So we just hear about this a lot, insinuated and even overtly stated in the addiction world. So as a reminder of the ASAM levels of care. So there's a level 1 is outpatient, like once a week, usually outpatient with a therapist. Level 2 is intensive outpatient treatment, which is usually 3 or 4 3-hour sessions per week for 6 to 12 weeks. And then level 3 is residential treatment, which is you live in the program and it's full time. And then level 4 is hospital-based care. So there are hybrids, and they're sometimes assigned decimals. For example, level 2.9 would be almost residential. So it's a full-time program, but they may not live on the site where they're in treatment. So they live in a sober living or somewhere nearby. And there's lots of different varied components for treatment, and this can be broken down in a lot more detail. So you can actually get lots of decimals in a way if you look at it in more detail. So this is just kind of a chart showing all these services on the outside that can be part of an addiction treatment program, such as childcare, vocational, mental health, medical, educational, HIV/AIDS, legal, financial, housing and transportation, family. And then in the inside is just a sample of the different processes, the intake and assessment process, the treatment planning, the pharmacotherapy, continuing care, monitoring, self-help and peer support groups, behavioral therapy and counseling, clinical and case management. And there are others. So, experiential therapies and things like that. So you can look at treatment as sort of a cluster of these things. And, typically residential or inpatient programs have more of these because they have more time to be with the patient. And they have different qualities of these too. So they may have more intensive family programs and so forth. So some of the components, of addiction treatment would include withdrawal management or detox, evaluation, and that can be limited or extensive. So a lot of programs may just give the SASSI and have a brief questionnaire. The SASSI is SASSI. It's the Substance Abuse Survey. That's a standardized test. So they can be brief, or it can involve a psychiatrist, psychologist, and more advanced psych testing and more advanced drug testing and hair and so forth. So evaluation can be quite varied. And then other components, treatment of co-occurring disorders. So, does the program have a psychiatrist involved? And are other addictive behaviors addressed? Education, I won't belabor this, but there's just lots of components that include lots of different things. And so different kinds of programs have different components. So the ASAM criteria was developed probably 20 years, 30 years ago. Dr. Mi Lee from Hawaii was one of the originators of this, and many others have weighed in and helped develop it. It was originally called the ASAM placement criteria, and now they've shortened it to just the ASAM criteria. But it's supposed to be an authoritative guide for deciding what level of care is appropriate for an individual. And so to do that, they developed 6 dimensions, right? So these are the 6 dimensions. The physical aspects of addiction are a lot of times just the intoxication and withdrawal. So how severe is that? So each of these is ranked by severity. Biomedical conditions and complications. Is the person having a GI bleed or a dementia or things that affect, that are biomedical? Emotional behavioral, actually dementia's there with cognitive. So sorry about that, but biomedical is physical health issues, emotional, behavioral, or cognitive, readiness to change, relapse potential, recovery, and living environment. So these sound good, and I think this was well thought out. Unfortunately, kind of what's happened is they've been used by insurance companies to deny care, and we're going to get more into that in a minute. So the latest version of the ASAM criteria also has a whole chapter on persons and safety sensitive occupations. Insurance companies like to deny or to ignore this chapter, but it says that additional factors should be considered, and there's a number of them. Among them are, the issue of risk to the public. For example, an outpatient program may not be appropriate for a police officer to keep working while he's in outpatient treatment, or for a doctor, or for an airline pilot. So risk to the public comes into play. And then it mentions the benefit of cohort-specific treatment. So with some professionals in safety-sensitive positions, it's important that they have peers because it helps them better address the issues and the shame and guilt and all the issues that come with that. And for safety-sensitive professionals, a lot of times because they're likely to be off work and need excellent care, it's sort of more intensive work or treatment over a shorter period of time may be appropriate. So each of the 6 ASAM criteria that I mentioned before, unfortunately, are relatively subjective. And as I mentioned, they're often used by insurance companies to deny care. And it gives the insurance companies, unfortunately, it's kind of backfired. It gives the insurance companies the facade of legitimacy to undermine appropriate care. So insurance companies definitely prefer to ignore the chapter on safety-sensitive occupations. So they really don't want to recognize that certain professions may need a different form of care, different level of care. So what do I mean by that? So insurance companies may say, you know, if you say the person has elevated liver function tests, they may come back and say, well, that is a minor common complication of alcohol use, and it will resolve just with stopping alcohol, and they don't need a higher level of care. Under biomedical conditions and complications, actually, that's what I just referenced. Biomedical conditions and complications such as liver enzymes elevated. Withdrawal, they might say the withdrawal is mild and doesn't warrant a higher level of care. That it can be done on an outpatient basis. Again, it's subjective. Emotional, behavioral, or cognitive, again, they, why that keeps jumping. They may be, you know, they may have bipolar, but the insurance company claims that it's stable. Their bipolar disorder may be stable, etc. Their depression's not that severe. It'll clear up once they get off alcohol, that kind of thing. They'll claim that the patient is ready to change because they showed up at a treatment center. So that couldn't be significant. Relapse potential, they've only relapsed twice, you know, and it often takes more than that, the insurance company might say. So that would be low. Recovery living environment, they have a home that, you know, so that's low. So as you see, the insurance company can argue on all these criteria that they're not severe, and then we're arguing that they are severe, that there's, you know, for example, they continue to have mild withdrawal after a week. And by the way, a lot of insurance companies will deny coverage if the person hasn't used the drug in a week. And so they'll say, well, he doesn't need treatment. He's been off alcohol for a week. Well, they may be continuing to have withdrawal that's significant. They may have liver enzyme elevations that are severe. They could even be jaundiced. They may have severe depression or other emotional, behavioral, or cognitive conditions. You know, there may be still some denial. They may have relapsed before. They may have conflict in their home with their spouse. So we would argue all these things are more severe, and the insurance company comes back and argues they aren't. So then they deny care based on their assessment. So I wanted to talk a little about the Mental Health Parity and Addiction Equity Act. So this is the law that passed in 1992 after 45 years of lobbying for fairness in insurance coverage. So it started back in the Kennedy era, and then it was reinforced by the Obamacare law in 2008. So this MHPAEA, Mental Health Parity and Addiction Equity Act, requires equality in care management as well as every other aspect of coverage. So what is care management? That's the prior authorization and concurrent review process. So if the insurance company is going to have a different prior authorization process for mental health than their physical health disorders that they insure you for, that would be illegal. And they have to have the same concurrent review process. Otherwise, that would be illegal. So where am I now? Let's see, got jumped around. Forward, backward. I don't know why this is jumping around on its own. Okay. Hang on a sec. Okay. So implementing the MHPAEA has been difficult because it requires judgment about whether comparable processes, strategies, and so forth are equal or not. It's become casually codified and largely uncoupled from care management, and insurance companies definitely continue to have economic incentives to avoid coverage. So basically, the mental health, the parity laws have been a failure. So this is a slide. I'm trying to get it so I can see the top. Um, it's, oh shoot, okay. It is examples of violations. And by the way, there have been very few prosecutions. There's 200 people employed um, at the site where this stuff occurs in the federal government. I'll say more about that in a minute, but there have been very few prosecutions. So these are the kinds of things that have been prosecuted, charging higher copays, imposing uh, limits for outpatient visits, um, not offering out of network providers or inpatient benefits to treat mental health or substance use. Imposing, this is probably the most blatant one, is imposing broad pre-authorization requirements. So they don't do that for physical health issues like they do for mental health by any means. They would require like a written treatment plan before they'll approve treatment. They don't require that if you enter the hospital with pneumonia. Dollar limits and disclosing the criteria they use to determine necessity. It's just laughable, really. So the organization that has the 200 employees is the Employee Benefits Security Administration. And so this law, the MHPAEA, is spread over actually 3 government agencies: the Treasury Department, this EBSA, which is it's under the Department of Labor, and then it's also under CMS. So part of the problem is there's not a centralized focus. But 100, this organization in the federal government, and this is their phone number, they have benefit advisors, and these folks actually can call your insurance company for you. Here's an example. This mother contacted the EBSA. Her child was in need of treatment for addiction and was required to seek care in an inpatient setting for 6 weeks, according to the doctor that referred her her child for treatment. The mother paid for the treatment out of pocket and then sought reimbursement from her group health plan. The plan had approved the first 3 weeks of coverage, but not denied coverage for the remainder. Additionally, while the plan approved the first 3 weeks, the mother had not received reimbursement months after receiving the approval. So the benefit plan advisor contacted the plan, inquired about the delay, and suddenly it got better. She got the $34,000 and information on how to make an appeal for the other 3 weeks that were required. So I mention all that to say this is not a bad number to give your patients when they're denied coverage. They can call the EBSA. The problem is it's probably slow. I don't know for sure, but I'm referring people to them. And occasionally we've seen benefits from it. The Center on Health Insurance Reforms at Georgetown University Health Policy Institute, they did studies, and over 10 years after the law was passed, there's not been any parity. So it's failed. There's some, but it's improved, but there's not parity. There's significant disparities in out-of-network utilization rates and provider reimbursement rates. So you can actually, this organization has done a study. So states have to have similar laws that back up the federal law, and each state has been ranked. Well, California got an F. And I looked around, and some other states like Alabama got a C. So it's just kind of incredible that Alabama did better on this than California. It's like, how could that be? But anyway, California does not do a good job as a state of enforcing the federal law. States are required to enforce it, and they can even have more strict requirements, but California does a poor job at doing it. The APA, American Psychiatric Association, puts out a brochure, or actually it comes in a wall like poster. The title of it is "It's the Law," and you can get this poster at the psychiatry.org website, and it lists about 10 things that your patient should know, and I just pulled off 4 of them because these are the law in the United States. Your health plan cannot require you to fail first at a less expensive treatment. Co-payment should not be higher for mental health. Mental health and substance use disorder treatment related visits should not require pre-authorization unless your plan requires pre-authorization for other medical care, and you have the right to appeal. So if any of these things, and there's 10 of them, are denied, then calling that organization is a good idea. So back to the dimensions. So each of these is ranked, and I kind of went over how the insurance company can manipulate those and to their benefit. Has Matt joined us yet? Guess not. Okay, he may join us soon. So I just wanted to talk a little about how does a doctor decide how aggressive to treat any illness? And I came up with some ideas. I was a internist for 15 years, and I thought about my time in internal medicine. How do I decide whether to treat somebody on an outpatient basis or an inpatient basis? And so one thing is we always want to use the most effective therapy if possible, or do we want to try a less aggressive therapy and save the quote big guns for later? So that's always a dichotomy that doctors have to think about. Do we want to do the best possible or try less aggressive therapy and it might work? And if it doesn't work, then we can put somebody in the hospital, for example. So for example, community acquired pneumonia. So you can admit somebody to the hospital that comes down with a lobar pneumonia with fever and cough. There is a risk of death from that. But if they're young and healthy, you might want to hydrate them at home and give them a broad spectrum antibiotic. And only if they get sicker would you put them in the hospital. Or do you go ahead and put them in the hospital and start, get cultures and start stronger IV antibiotics? And so which way is right? I think personally that starting with the strongest IV antibiotics is important because people can die of pneumonia. And so I think more and more people are put in the hospital for lobar pneumonia, at least for a few days. Okay. Typically, the more casual the approach on any condition, the higher the risk. And so, but typically the more aggressive approach is more costly and intrusive. So people have to stop working or something like that. So the physician and the patient must decide. And now the insurance company gets involved, and they get involved more when it's mental health or substance use, as you guys know. So what factors need to be considered in deciding how to aggressive to treat an illness? So these are the 6 factors I came up with. Well, what are the facts regarding success rates for more limited versus aggressive treatment? Or you could put it the other way around. What is the death rate or the failure rate from more limited versus aggressive treatment? So are there facts that show that one is better than the other? 2, what are the risks associated with more limited treatment? If you don't do the most aggressive thing, is there a higher risk? And then 3, what are the risks of the more aggressive treatment? So sometimes the more aggressive treatment could be riskier. So that should be weighed in. Are there comorbidities that make the benefits or risks different? So if somebody had, if they're older and they have kidney failure and they come down with pneumonia, you would be more likely to put them in the hospital because they have comorbidities. What is the availability of the various forms of treatment? So are you near a hospital? Is it hard to get them, more intensive treatment? Or are you out in the boonies where you might be more apt to try less aggressive therapy? And then finally, is there a different rate of coverage by the insurance company on more aggressive or less aggressive? Because people care about cost. So all these factors, you may think of other ones, but these factors go through the mind of a physician when they just try to decide, like, how aggressive should I be about treating an illness, any illness. So let's take those individually and talk about um, about uh, addiction treatment. So if you compare, so the first one is what's the difference in success or failure with limited versus aggressive therapy? So there's been inconsistent data that studies have not conclusively shown that inpatient treatment is less or more successful than outpatient, but some have shown that. The main reason is because people are retained better in inpatient treatment, according to some studies. But there's not been good double-blind. There's no way to blind this, and there's been few controlled studies. But we know that treatment retention is important. There's many anecdotal reports from patients. I hear it all the time when people tell me they compare an inpatient stay they've had with an outpatient stay, and they say there's no comparison. The focus, the intensity is much more significant. So, but we lack hard, for sure, data on this. What are the risks of limited treatment? So those have a big factor. So with licensed professionals in particular, relapse is very risky and can make them lose their career, can cause harm to a patient that would further risk their career. So the risk of limited treatment and risking a higher chance of failure can be quite detrimental. And then you've got like boards, hospitals, medical groups. They'll be supportive of the first trial of addiction treatment, but a lot of times when somebody fails, so there's a lot of one strike you're out kind of concepts. If they fail outpatient treatment, they can be, they can lose their job. And then, of course, there's liability concerns. Outpatient treatment is really designed so that people can work while they're in treatment. And really, professionals in safety-sensitive occupations should not work while they're in outpatient treatment. The liability risk is too high. If there's any kind of untoward outcome, then, and if the plaintiff finds out they were in addiction treatment while this occurred, there's a high risk that could lead to a failure in a lawsuit. 3, what are the risks of more aggressive inpatient treatment? So is there a risk to treating somebody more aggressively? So they could have their practice closed if they can't work. It's feared, but rarely occurs in my experience. Usually doctors think that the world will stop if they aren't there at work. But in fact, people get by, and often the patients flock back to them when they get back from treatment. So there's a lot of fear around, my practice will never survive this, but usually, almost always, there's no problem. It's almost unheard of for a practice to close. Certainly they have loss of income. Hi, Matt. Thanks for joining us.
Yep. Sorry for running late.
That's okay. So we're just going through and talking about how doctors decide about levels of care. So if they go to a more aggressive level of care, say inpatient, they're going to lose income. Um, but they really can't work while they're in outpatient either. So there's really no difference there. And then it's usually, I put here, it's usually advisable to treat addiction as thoroughly as possible from the beginning because it's a serious illness. There's a certain fatality rate, and it's definitely very destructive to somebody's life in every aspect of their life. So why shouldn't we consider it like cancer? So it's usually advisable, in my opinion, to be more aggressive rather than risk recurrence. And that would be the way you would normally think of treating cancer. Matt, jump in if you have comments. And we'll do a Q&A soon. Another factor to consider when deciding how aggressive to be are there comorbidities that make the benefits versus risk different for more aggressive treatment? And that's where you can bring into play the ASAM criteria, because if there are co-occurring psychiatric disorders, troublesome personality traits, narcissistic, borderline, all the personality disorder traits can be a problem. If they have other process addictions, sex, gambling, etc., that can certainly be a comorbidity that can make things more difficult. Previous relapses, the home situation can matter if there's conflict in the home. 5, what's the availability of the various forms of treatment? Well, there really is not a problem finding full-time treatment programs, which are either PHP or residential for professionals. There are a relatively limited number around the country, maybe 20 or 30 programs, but it should not be too hard. And there would be more if insurance companies covered better this type of care. And then finally, are the various forms of treatment covered by insurance? If you're going to have somebody in outpatient or inpatient, is there a difference in coverage? So typically and inappropriately, based on the parity law, insurance companies do not cover inpatient, residential, or PHP as well as outpatient. But when you're talking to a patient, risking relapse or the consequences of addiction can be very costly. Loss of career, having to hire attorneys, go through hearings, etc. So would they be well advised to take time off, get intensive treatment, and have a better chance of doing well and lower the cost possibly of the administrative aspects, especially if it was related to relapse? And then the whole issue of cost is sort of mitigated, and I don't want to overemphasize this, but most professionals are fortunate to have financial resources to obtain the best care. And as an example, what doctor wouldn't want to go get the best possible cancer treatment? And would they be saying, I really can't afford it? Kind of doubt it. Okay, they're going to figure out some way to, pay for travel to MD Anderson or wherever to get the best possible treatment for cancer. And so there's this unusual situation here where addiction leads to, a lot of times professionals are looking for the least expensive and shortest duration treatment possible. So that's the odd thing about this illness. Okay, so in conclusion, treatment of licensed professionals in safety sensitive positions, in my opinion, should be aggressive and thorough to preserve careers and lives and get the best outcomes. The ASAM criteria chapter to address this issue is helpful, but can be ignored by insurance companies. And I've developed a letter that I like to send out that emphasizes the points in the ASAM criteria chapter on safety sensitive occupations to the insurance companies in terms of appeals. And then finally, really the concept of failing up, it's not only illegal according to the parity law, but it should be avoided when working with licensed professionals. So I think that concludes that part of my talk. And Matt, did you have any comments from what you heard, or you've seen the slides?
Yeah, no, I think you went through the different components really well, and it's always difficult because you may have already said this before I joined, but it's we always want people to get a little more treatment than they need versus a little less treatment than they need, because a little less could lead to relapses, further issues with the board, with their families, their license. So it's a difficult balance of finding the appropriate level of care for somebody who has a lot on the line, and not undershooting it and then leaving them vulnerable to a relapse and needing further treatment down the line, which can be even more costly and more devastating. So it's a hard balance to try to find objective measures, which I think your slides showed what we try to look at objectively to figure out what's the right program, what's the right level of care, length of stay, all those kinds of things.
Thanks, Matt. So I'm going to open it up to questions.
Got a question from Dr. Sucher, if I might read it.
Sure.
If you identify a physician or other health professionals early in their disease process, say mild, early, moderate stage, why could they not do intensive outpatient treatment and continue to work, particularly if the patient or family self-identify and seek treatment early before board reports, work-related incidents, DUIs, etc.?
Well, I'll comment and then see if Matt has comments, but thanks, Mike, for the question. So the issue of liability is one thing. So if you're intending for that person to continue working while they're in an IOP, then I think it should be, there really should be a question about liability, as I mentioned earlier. If there's any kind of thing that happens, untoward event, and the patient or the malpractice company or the plaintiff who's suing finds out that this doctor was in outpatient treatment for alcohol use disorder while they were treating this patient, you're dead meat, and I've seen cases like that. So there's the liability issue. So then you could say, well, why not let them in outpatient and they just stay off work while they're in outpatient? Well, the issue there is, why wouldn't they do full-time treatment? They have the time if they're not working. And the full-time treatment could be shorter duration, more intensive, and they could be with peers and so forth. The third thing I want to comment on is the fact that some of the most difficult patients I've ever treated are the milder cases. People that hit bottom, as they say in recovery circles, that have disastrous consequences. They're the easiest to treat a lot of times because they have hit bottom and they're willing to follow directions and do whatever it takes. And the ones that are the mildest still have denial. And it really benefits them to be with peers and think it over more thoroughly and hear about the disastrous cases. So I think it's important, really, for doctors to take time off work and do intensive treatment. Matt, do you have comments?
Yeah, I mean, I obviously agree with what you said, and I think that answers the question well. The only thing I'd add is, from where I've seen, it's hard, even in mild cases, for physicians or other healthcare providers to feel comfortable sharing. A lot of times they'll say, oh, I couldn't go to AA because I was afraid I'd see a patient there. I couldn't go to the IOP because what happens if I ran into somebody that we know? And so I think one of the things that's difficult is it's hard for a healthcare provider to take that hat off. And if they go to an IOP, I've heard stories and seen, they'll show up in a white coat, or, they'll be helping diagnose skin cancers and moles to the other patients in the program. And so one of the things, we often talk to the patients about, who are physicians and healthcare providers, is you really have to be the patient and you have to be open and honest. And so I think it may be, for the reasons that Dr. Skipper already said, difficult in those mild cases for somebody to break through the denial. But it's also hard because it presents another opportunity for the addiction to give an excuse not to be honest. Well, if you say too much, or if a patient hears it. So I think going to a program that is designed for healthcare providers, and so they have that space and that confidence that they can be open and honest and get the care they need, will go a lot farther in the long run than trying a lower level IOP, where for all of those reasons they're not going to get the care they need, and it almost kicks the can down the road. So it's not to say it can't happen, but it's another reason where I've seen it not work. They've tried that and they just couldn't get what they needed, partially because they didn't feel they could, or they were able to be open and honest. And I think it's important to have the right fit, so they
Mike,
can.
do you have any comments about that? You can unmute and talk if you want. Okay.
Yeah, no, hey, Greg,
Yeah,
sorry.
yeah. It's a tough decision.
Well, I mean, I see both sides of it, but I think there's going to be, and I particularly see the liability side. But I wonder how frequently there really are malpractice for those kinds of claims that happen to occur while the person's in treatment. And if they're in treatment and compliant, that may really bolster their defense, frankly. And I was just typing another question for you guys. This is a great topic. I'm really glad you're doing this. I hope you have a lot of attendees. I can't see what you got, but the Federation is, in the process of developing two programs, one to evaluate PHPs, but another to evaluate treatment and evaluation programs.
Yeah.
And what I didn't know, and maybe you do, is whether that includes intensive outpatient as well as various levels of residential treatment. And if, along with, let's say they approve 30 treatment centers and 5 of them are outpatient programs, I wonder if they're going to also have criteria, in addition to the ASAM criteria, when one level of care is appropriate over another.
That's a good question. I don't know the answer with certainty, even though I'm on the committee that's looking at the rules for the accreditation of treatment centers. I can't remember. I'm guessing that intensive outpatient programs are included, but based on all the criteria that they're developing, they may have a hard time being accredited because they're looking at like full-time medical director and lots of requirements that may be hard for an IOP to have. So, but we'll see.
Well, I only ask because, I've been helping some folks develop a virtual IOP for health professionals that would include a lot of elements that a residential program might offer, but also, would allow somebody to get into treatment before they hit a negative consequence and continue to practice. And I wonder also if you think, is there a difference in what specialty you're in?
Yeah, good point.
If you continue to work as a family medicine physician or an internist versus a neurosurgeon, for example.
Oh, I think that's an excellent point. That it does. I think the risk level and the concern level goes up. If you have somebody tinkering around in your brain operating, that's a higher concern than, say, a psychiatrist. Psychiatrists never do anything that's very risky. I'm just kidding.
Well,
a little jab for Matt there.
And that's without even getting into the topic of working on MAT.
Yeah, that is another whole big question. Oh yeah. I think we won't tackle that one right now, but we ought to have a webinar on it. It's a big one.
Yeah. Okay.
Any other questions from attendees? Feel free to either post a chat question or just speak up, unmute yourself and speak up if you like.
Greg, this is Tom Specht.
Hey, Tom.
And hi, Mike.
Hi, Tom.
So along the lines of what you were saying, Mike, that there's going to be an evaluation of programs, I assume that's going to be data driven, and I'm wondering what they're using as the metrics for that evaluation. And Greg, earlier you said that, one of the things that supports the residential, which I personally totally agree with you on, is kind of the anecdotal stories. But is there any data in terms of, length of sobriety or recurrence of relapse or whatever that would support that further in a data manner?
I looked at the data and it's all over the place. And unfortunately, it's sort of hard to interpret because there's so many different qualities of programs and different study designs, but some have shown improved outcomes with more intensive inpatient. Others have shown no difference. It's really hard to tease it apart. And none have looked at professionals. Now, there is data, of course, on the outcome for professionals, and it's excellent. But it's hard to say that's all due to treatment, because they get long-term intensive monitoring, and that's another big reason they do well. I think the biggest thing to say for take time off from work and get intensive treatment is to take a break, get out of your role, get honest, fully participate, change your life. It's hard to, long-term sobriety is not an easy challenge. It takes, as they say in AA, only one thing needs to change. That's everything. Kind of silly, but it's kind of true. Any other questions or comments? Feel free to jump in.
Yeah, here's a question. How should length of stay at the residential level be determined?
So yeah, Matt and I have worked on that at our facility. So we've tried to. Do you want to tell them about it, Matt? What we've done?
Yeah, I don't have the specific ones memorized in my head, but yeah, we've tried to use, I think, a combination of, ASAM placement criteria and then how they're doing in our treatment program and reaching their treatment goals as a rating scale. And once they get below a certain score, gives us an indication that they're potentially discharge ready. So I think it helps to make it more objective, also individualizes it towards the patient, and so they are aware of what their goals are and how to reach them. Greg, you probably have them memorized. You want to go through those factors?
Yeah, we look at like recovery, and we call it recovery resistance because the higher the score, the worse. So if somebody's not really embracing peer support, mutual support groups of whatever type, and they're not really on board with accepting help, then that would be a high score. Then we have co-occurring disorders. So depends on what the co-occurring disorders are, but we rate those. How stable are they? We have family system issues. So see, it's a little similar to the placement criteria. Family system, are they supportive? Have they participated? And then we look at, legal, administrative, what's going on with their work, their license, their legal issues. And then finally, the last one is the reference standards and their desire. So if somebody's referred from a program that insists on longer lengths of stay, then that's factored down. Hope that helps. And then we look at other things too. The accomplishment of goals that they set, and the general feeling of the team toward the patient. But we like to have these objective things when we can. Any other questions or comments from anybody?
I'd like to say something.
Okay.
Hello, everyone. I'm a therapist, master's level therapist. I worked at Talbot in the heyday in the 90s, and I'm now the director of the peer assistance program for dentists in Georgia.
And what's your name?
Jane Walter.
Great.
I've met you before,
Hey, Jane.
years and years ago. Yeah. So I think one thing that I have seen for 20 years, I've been on the monitoring and advocacy side. Prior to that, I worked in treatment for a long time, probably longer than I want to tell y'all. But 8 years at Talbot, and you know my old boss very well, Jerry Groper.
Oh, yeah.
So, and I'm having lunch Monday with Barry Lubin. Barry and I are big friends. So, but I think one of the things that I didn't hear mentioned that's sometimes difficult to mention is the reason that inpatient and long-term therapy works better, treatment works better for health professionals is the difficulty that most health professionals have in becoming a patient. You know, as somebody said, changing hats, but
Right.
my experience is that lesser levels of treatment usually are not effective for long-term recovery, mainly because of the character defects that, you know, are developed in addiction and also kind of inherent in being a health professional.
You're right on, Jane. I think that's so true.
The reason I tuned in today, I get your, somehow I got on your email list a long time ago, but I wanted to hear what you had to say because I'm in the position of sending people to treatment, and I've been uncomfortable with this trend that seems to be happening in some treatment facilities around the country of the shorter term treatment. So I'm one of those that if I send somebody to treatment, I like to speak with the treatment team about at least, you know, a full complete treatment, which is still, I think, 90 days.
Great comments. You know, there is good data that the longer somebody is in treatment, the better the outcome. It does not specify specifically that it has to be inpatient, but there is pretty good data. Tom McClellan and others have studied length of treatment, and outcomes improve with longer treatment. 90 days, they say, should be the minimum. But again, they would say it doesn't have to be all inpatient.
Right.
But, you know, if somebody can stay off work and do that longer treatment, which almost everybody can if they have to, then I believe they do better as well. Sally Ann, I saw your hand raised. Can you feel free to unmute and say something?
Well, hello, Chief.
Hey.
Hello, Dr. Sucher and Dr. Goldenberg, my dream team.
Hey.
I miss y'all.
Yeah,
So,
I miss you.
To kind of, you know, expand upon what Jane was just saying, you know, coming from, you know, inpatient, working alongside you, Dr. Skipper and Dr. Goldenberg for many years in the inpatient setting, and now transitioning to, as you all know, I'm conducting the monitoring program. And I agree with Jane, there's truly a vast difference in the physicians and healthcare professionals who are coming out of an inpatient program versus somebody coming out of an IOP program. And what I'm beginning to recognize is that a lot of the physicians, especially coming out of the IOP programs, are relapsing. You know, I think a lot of that, there's multiple reasons, but I'm wondering when we're talking about outcome studies, you know, I'm wondering if at some point in the future, there might be an opportunity to kind of marry the inpatient setting and the clients who follow up with monitoring and look at that, maybe a small cohort to see who is actually still sober. Because, and especially I'll share with you the physicians coming out of the seasons program that are in my monitoring, they are coming up on 2 years of sobriety.
Wow.
Yeah.
Yeah, great comments. Thanks, Sally Ann. Does anybody else have comments? Well, I'd like to thank everybody for participating.
There's one more, if you don't mind.
Okay, go ahead.
Got a question from Jenny Matthews with Maximus in California, who operates the diversion programs for many healthcare licensing boards. Hi, guys. There are two pretty big factors affecting a patient/participant entering more intensive levels of treatment, patient resistance, and the pandemic. Would you mind talking about overcoming these factors?
Thanks, Jenny. Yeah, I forgot about the pandemic.
Yeah.
Patient resistance, though, I think we just have to encourage people and give them these thoughts that we've just talked about, and I do think that, Mike weighed in, and I agree to some degree with what he's saying, but I usually just tell people, look, you need to take off work. You can't be in addiction treatment while you're working. And usually the employer agrees. And if you're going to be off work, you need to do more intensive treatment. It's just a waste of time not to, and you can get back to work sooner, theoretically. And they may be still resistant. And then it becomes a matter of setting limits if you're in a position to set limits. So if they call me, I'm not in a position to set limits, but I give them the argument that they're going to be with peers. It's going to be more intensive. They get more out of it, and they can hopefully get back to work sooner. They shouldn't be working anyway.
Well, Greg, let me just interrupt. The program I'm working on with some folks is a virtual IOP for healthcare professionals.
Oh, yeah.
So you'd have to be a physician or a dentist or a nurse or some other health professional to get into it. And particularly since Ginny brought up the issue of COVID, which sort of makes this very timely, is that they would be able to participate in treatment with virtual groups, individual education, even coaching sessions during this treatment program. And again, the employer may not know and probably wouldn't know, because again, these are patients who might be seeking treatment before they have a calamity that, makes it much more difficult. I agree with what you said about the simple or early cases being more challenging than the, later stage cases,
Yeah.
because you're right. I mean, if you're facing all kinds of people coming at you legally, administratively, employment-wise, it's easier to get your attention. But on the other hand, if you got somebody who says, I know I'm getting in trouble, I think I'd like to get help before it gets worse, and they could do it virtually and work before any of those other parties, including their employer, are alerted, and particularly for people practicing on their own too, self-employed, solo, or small group practices.
Well, it sounds like there could really be a place for that, especially when people want to get help early, and if there's something like that gives them confidentiality and good care, that's great. Our COVID policy right now, we go by CDC guidelines, and we're requiring that people have a negative test before they come into treatment, and if they don't, then we perform a test when they arrive and put them in quarantine until we get the result. And then we're not allowing people to do outside meetings right now. They're doing it by Zoom, but we supervise that and make sure they're going to meetings. Actually, there is one meeting that is on the beach where people sit outside separated and they use a microphone that we have started letting our patients go to on Zuma Beach nearby. But, we have protocols, so there's no visitors, except with some exceptions outside. And so we've tightened it up, and we've had no problem so far. Anyway, listen, thanks everybody for participating. What a great group. And we'll do this again sometime. I really appreciate the comments and the participation. And thanks, Matt, for coming on board and helping us.
Happy to be here.
And thanks for our team that put this together, Jim and Raj and Divya and Chris. Thanks, everybody.
Yes, thanks.
Thank you.
Thank
Bye,
you.
everybody.
Thank you.